describe why I chose to target individuals, or the individual level of the burnout issue, and the data supporting this approach. And then I'm going to zoom out a little bit just to talk about the systems and culture at UCSF that have evolved over several years since we began individual stress resilience training. And then, of course, finally, how this work has been affected by COVID-19. So more than a decade after the American College of Surgeons, Tate Shanafelt and Charles Balch, who was at Hopkins at the time, published the landmark study on burnout in surgeons, we continue to wrangle over exactly how to define and measure this phenomenon. Most people agree that burnout is a prolonged response to chronic job-related stress, and that it's comprised of 3 subdomains: emotional exhaustion, depersonalization, and personal ineffectiveness. But as it turns out, people can have burnout in one or more of these entities, and symptoms can be measured by the day, week, month, or year. And so this just means that there's multiple ways to define burnout, and making comparisons across studies has been challenging. But this recent publication, in fact, it just came out last week, from Carl Billamoria's group at Northwestern, looked at 2019 ABSITE-related burnout survey data from nearly 7,000 general surgery residents. And they found that really, regardless of how burnout was defined within those parameters I described, that it was significantly associated with increased thoughts of attrition and suicide. So we know that burnout is indeed serious, and there's extensive negative personal and professional effects of burnout. Multiple studies have demonstrated these in terms of addiction, mental illness, compromised performance, and attrition from the field. And then furthermore, more recently, Tate Shanafelt's group did a really lovely analysis using kind of a complex mathematical model to estimate the annual cost attributable to burnout based on attrition and decreased productivity of physicians across specialties. And that price tag was $4.6 billion. And breaking it down a little bit, almost 40% of that cost was derived from burnout in surgeons, and 82% of that was due to attrition. But particularly striking to me was 64% of that attrition was among surgeons less than 55 years old, with a cost of about $900 million. So it's increasingly clear as well that burnout is really a surrogate marker of profound distress. So as seen here from a smaller national survey that we conducted in 2017, what we found was that there was an increased risk of suicidal tendencies and mental illness when high burnout was present. But of particular interest to me, that when overwhelming stress was present, odds of these negative outcomes increased 2 to 5-fold. And this is not entirely surprising. There's decades of research that have shown us that when stress becomes overwhelming, that is when demands outstrip our internal and external resources, we enter threat mode. And over time, threat mode leads to physiologic, social, and cognitive deterioration. And this is typified by the right side of this inverted U-shaped curve. But what's interesting is that stress is actually a heterogeneous entity, meaning it's not all bad. And in fact, on the other side of this inverted U curve, we have good stress. So this is the kind of stress that feels challenging, stress that is necessary to stimulate adaptation and mastery, and which I would argue most of us in surgery are both familiar with and to one degree or another attracted to. So the overriding question in my early work was, how can we shift people's experience of stressors away from threat and towards challenge? And so a clue to how this might be done came from that same national survey of general surgery residents, and our finding that individuals with higher inherent mindfulness tendencies, so this is not necessarily the product of formal training, but rather natural tendencies towards certain ways of thinking about and acting on the world. These people had significant reduced risk of having burnout, overwhelming stress, anxiety, depression, and suicidal thoughts. So what is mindfulness, and what is mindfulness training, and what exactly do these things do? So this diagram, generously lent to me by Celia Divino at Mount Sinai, describes a commonplace scenario. We're going about our lives and some event happens. This can be good or bad, and invariably we respond. But being that we're human and time compressed, our responses are often reflexive or influenced by stress. Occasionally, like when we're rested and happy, our responses are thoughtful and considered. In general, these lead to better outcomes. So while this scenario might actually seem unremarkable, it is in fact critical. How we respond to life's events is directly related to the quality of the lives we live. So as Viktor Frankl puts it, between stimulus and response, there's a space, and in that space is our power to choose. In our response lies our growth and our freedom. And this is where mindfulness training intervenes. Mindfulness training teaches us to recognize this intervening space and to take advantage of it. We become able to respond to life's events and not just react, even when we're tired, angry, and stressed. And mindfulness training accomplishes this by cultivating our ability to pay attention to experiences occurring in the present moment and to observe those experiences without reacting. More simply put, mindfulness training is a way of training the mind to both sustain focus and open awareness, which essentially amounts to training the mind in a different way of perceiving the world. So in fact, this is not a newfangled idea. As Albert Einstein put it almost 100 years ago, we must remember that we do not observe nature as it actually exists, but nature exposed to our methods of perception. This determines what we can or cannot observe. Reality is an illusion, albeit a persistent one. So specifically, mindfulness training is not a way to ignore what's going on around us, nor is it a way to become perpetually happy with intolerable situations. It is in fact a way to change perception, to clarify our vision and increase our options, allowing us to navigate life in a different way. And these skills are specifically developed through the practice of mindfulness meditation. So according to Barbara Friedrichson's broaden and build theory, which in part explains why resilient individuals seem to perpetuate their own good fortune, one result of practicing mindfulness meditation is the cultivation of positive emotions. Supported by both theory and evidence, positive emotions are believed to broaden our cognitive and behavioral repertoires, which strengthen our internal and external resources. This phenomenon, referred to as the upward spiral of positive emotions, enables individuals to call on a wider than usual range of ideas and actions, creating behavioral flexibility that builds personal resources like confidence, resilience, social connections, and even physical health. And this incremental accrual of internal and external resources through the cultivation of positive emotions is theorized to have given our ancestors an evolutionary advantage. But of course, among surgeons in modern times, mindfulness-based cognitive skills serve to strengthen our performance. That can be whether it's mastery of complex technical skills, our professionalism, our relationships, or prosociality. But by addressing the psychological state of the individual, by improving self and situational awareness, and by providing discrete tools to emotionally and physically regulate the stress response, and then of course, practicing these things over and over, we increase our ability to live on the top of that inverted U-shaped curve. And this is a state that many of us are familiar with as flow. And the evidence supporting the clear value of mindfulness training is actually, at this point in time, quite extensive. It comes from institutions such as MIT, Oxford, Harvard, and Max Planck, which have demonstrated the ability of mindfulness-based interventions to reduce stress and enhance performance in myriad high-stress and high-performance populations. These include increased cognitive attention and decreased reintegration distress in Marines, better math scores and greater pro-social behavior in public school students, better perceived collaboration between parliamentarians, and sustained peak performance by gold medal Olympiads and multiple superstar athletes who use mindfulness training as part of their professional workout. And the wide applicability of mindfulness training speaks to this very central and therefore universal mechanism that we believe mindfulness training targets. This is, in fact, the way that we perceive stress. So although stress often feels like a force of nature, something thoroughly outside our control, this is in fact not the case. So consider all stressors, walking home alone on a dark street late at night, taking the Absite, or encountering unexpected bleeding in the OR, all these things feel the same. We have rapid breathing, heightened visual acuity, maybe even shaky hands. But while shadows moving on a dark street when we're alone might compel us to run, we're actually able to master these reactions elsewhere, like in the OR, and get down to business. So in fact, it is our minds that prevent us from reacting to all stressors in the same way. And this is the result of feedback between the body and mind, specifically the HPA axis and the prefrontal cortex. And this represents a process which we can intervene upon. So through ways we don't fully understand, mindfulness training enhances our ability to do this. So with all these ideas in mind, in 2016, we created a tailor form of mindfulness training for surgeons called Enhanced Stress Resilience Training, or ESRT. During ESRT, 90% of each class is spent in experiential training. So that means doing, not learning about through reading or lectures. So this is like a skills lab for cognitive training. It means physically practicing skills, and in particular, we focus on three main core abilities. The first is awareness, which is the moment-to-moment consciousness of thoughts, emotions, and sensations. The second thing is emotional regulation, which is learning to be non-reactive to experiences around you. And then third is metacognition, which is awareness of these processes and cultivating the ability to call on them more readily and as needed. So at this point in time, after these 4+ years, ESRT is now a formalized curriculum bundle. The course itself is 5 weekly 1-hour classes with graded daily practice and then booster sessions. It consists of a training manual, an app-based platform, and video components. And then it very much emphasizes the direct application of these skills to surgeons and surgical trainees' lives. And part of this includes videos from past participants discussing where, when, and how they use these skills. So here's an example of that.
So I use the mindfulness for a couple of different techniques throughout the day. I think one thing that's really helpful for me is mindful scrubbing in, meaning before we scrub into surgery, I like to take those 2 to 3 minutes to, instead of thinking about all the things that are waiting for me and the surgery that's coming in and everything else going on in life, I just practice mindfulness and completely focus myself so that when I go into the operating room, I'm completely calm, my heart rate's down, and I feel like that way I'm better centered going into the operating room. I think it's also very useful to transition between work and home. So before, I used to go home and kind of bring all the energy and the negativity and stress from the day home with me. Whereas if I practice mindfulness as I'm walking or driving home, I feel like that way I'm able to acknowledge the day, kind of let it go, and then go home without bringing it all home with me.
So over the last 5 years, we've conducted 2 randomized controlled trials with longitudinal follow-up and several pre-post cohort studies. It bears noting that the controls within our trials have all had the same protected time, close faculty interaction, and peer group community building as the ESRT intervention. The main difference is simply the absence of mindfulness training for the control groups. So in this context, we've been able to demonstrate several promising things. The first is that such an intervention like this is feasible within surgery. We found that ESRT participants were able to practice a mean of 5 days per week and 15 minutes per day for the duration of the course, and that to a lesser extent, they maintained these practices without any input from us over time. The second thing, we've been able to demonstrate statistically significant benefits in terms of ESRT participants, represented here by orange lines, having higher mindfulness scores and higher global executive function, which includes working memory capacity and cognitive control, like attention. And these are findings that mirror results of similar studies in Marines. Third, we've demonstrated statistically significant differences in emotional exhaustion and depersonalization, again with the ESRT folks represented by the orange line in both these figures. And then fourth, we've shown statistically significant effects of ESRT on physiologic markers of stress, specifically transcription factor activity for pro-inflammatory and beta-adrenergic signaling pathways. So specifically in controls, we saw that the experience of business as usual PGY1 surgical training resulted in about a 1.5-fold increase in fight or flight signaling and pro-inflammatory gene expression. These are findings that are similar to those found in populations suffering from sleep deprivation, chronic loneliness, or malnutrition. But in contrast, our ESRT participants had this effect mitigated by more than 50%. And this was only from a few hours of training at the beginning of their PGY1 year. So our fifth finding, through the use of blood oxygen level dependent functional neuroimaging during an emotional regulation task, we found that ESRT participants had unique activation of neural substrates in two specific areas: the dorsolateral prefrontal cortex, which is considered the executive control hub of executive function, and then the precuneus, which is an area of the brain associated with interoception and self-agency. These bright lights are difficult to interpret with accuracy because there's so much about the brain and how it works that we don't know. But at the very least, these findings suggest that when faced with an emotionally challenging situation, ESRT participants preferentially recruited areas of the brain associated with emotional regulation, complex problem solving, interoception, and self-agency. So in light of all this objective data and a parallel mountain of qualitative data, we do believe that our residents are learning to shift the curve. And in their own words, what this looks like is, for instance, when I get stressed, I tend to spiral in my mind. I start thinking I'm doing it all wrong. I'm no good, I shouldn't be here. ESRT helped me take a second to see this response and note it. Now I can float back to the top and recognize that this is just uncomfortable. It's stressful, but that's okay. Residency is just hard for everyone. Or from another person, once I learned being in the moment, I became aware of my body in the OR. I realized I would hold my breath, clench my stomach, but now I breathe. It brings everything back into focus. I see more clearly. Or the final one, somehow I've gained some space between me and my reactions. Those late night consults, hammer pages, I get so angry. Now I recognize this reaction. I can see things a bit differently. This isn't personal, they're just worried. Being angry won't make them stop, but getting that angry just hurts me twice. So, why focus on individual-based interventions? Because, one, as the data shows, individual interventions bring immediate, if not complete relief, directly to those who are at the greatest risk of suffering under burnout, which is individuals themselves. And two, while individuals aren't responsible for the problem of burnout, they are critical to guiding meaningful changes to promote well-being in the systems and culture around us. And three, there is complex interplay between systems, culture, and individuals that really requires concurrent and coordinated change on all three levels. So individual-based interventions are not the whole answer, but they are a critical part of the answer, and they do influence our progress overall. So, not surprisingly, in spite of this evidence base, surgeons still remain slow to adopt mental skills training in general, whether that's in the form of ESRT or other evidence-based practices like the performance-enhancing mental skills curriculum that was developed by Dimitri Stefanidis and Nick Anton at Indiana University, and which has been impressively tested in several randomized controlled trials. Some of this resistance can be addressed by utilizing implementation science and tools such as the Consolidated Framework for Implementation Research or the REAIM framework. These are both process models for optimizing the adoption of novel evidence-based practices by understanding barriers and facilitators, adapting content and delivery as needed, and then utilizing iterative feedback from the target population. And while we found these tools to be invaluable, perhaps the most critical facilitator of adopting ESRT was changing our local culture. And this came from early involvement of leadership and administrators, and then drenching people in data. Furthermore, we started with small cohorts of resident participants, recruiting them year after year. and then expanding to faculty thought leaders, and from there to larger groups of faculty and eventually bigger groups of residents. And then finally, we reached a tipping point where enough exposure, word of mouth endorsement, and normalization had occurred that something finally shifted. And proof of this shift is really seen in the inclusion of ESRT in formal surgical education for PGY1s for the first time at UCSF in 2020. And so leaping off of this, we're working to develop a longitudinal well-being curriculum, which is centered on mental skills training with level appropriate and setting specific applications. So for example, while ESRT is basic skills training in affective regulation and stress resilience, we can build on this by using things like the mental skills curriculum of Stephanides and Anton in order to help junior residents learn to moderate peak performance and anxiety when they're learning complex technical skills, and in particular, learning to translate those to the live OR. Or we can use curricula like the Join Work program from the Institute for Healthcare Improvement, which would allow lab residents to use their increased discretionary time and insider understanding of what residency is really like to drill down on quality improvement, but here it's specifically targeted towards inefficient and defective systems that contribute to resident burnout and work dissatisfaction. And then finally, for senior residents, taking this to a slightly different place by facilitating discussions with esteemed senior faculty who've trained in ESRT and can guide residents in how emotional regulation can be used to deal with intraoperative stress, complications, the challenges of leadership, or even litigation, all things which are arguably absolutely necessary for independence. So by shaping this internal curriculum, rooting it in mental skills training, we believe we can build surgeon leaders who look the same and perform the same on the outside, but who on the inside have a whole new set of remarkable skills. So at the heart of all of this is really a desire to bring joy back into our work, work that we have all sacrificed so much in order to be able to do. So although this wasn't a goal at the outset, this finding has emerged and is apparent in the subtext of this testimonial by one of our faculty participants, Dr. Hobart Harris.
So my favorite exercises are when I'm walking into the hospital at 5 a.m. to really pay attention to the feeling of the pavement under my feet. And I know it sounds kind of funny, but I find that is a very interesting way to just once again recenter and reclaim the kind of attention to the moment. Secondly, I like practicing meditation when I am waiting for things in the hospital, whether I'm waiting in pathology for a pathology result or on the elevator, waiting for the elevator. I find these short little moments, times that it's just nice to, once again, refocus.
So from this, we've come to turn our focus away from simply looking for pathology and towards trying to understand the building blocks of true well-being. And this is not at the expense of performance or rigor, but actually to align with it as an element of synergy, if you will. And so in the last year or so, we've begun to include measures like flourishing, which takes into account diverse individuals and environments, looking at the global effect of social, emotional, and psychological well-being. And this really gives us a different lens through which to view the status of our program and how our trainees are doing, which, for instance, in this 2019 survey of our resident body, we saw that in spite of 42% of people scoring high for perceived stress, 59% of those people also scored in the range of flourishing. So this suggests that perhaps not all stress is created equally, just as the inverted U-shaped curve would suggest, and that our understanding of this types of stressors, a more granular look at stressors, may help guide where we target interventions. So along these lines, from the same 2019 survey, we saw a significant positive correlation between flourishing and social support. And in fact, this echoes job strain theory, of the job strain theory of occupational science, which posits that social support can mitigate the effects of high demand work even further than the effect of increasing control. And this has been empirically shown to be especially true for women. Of course, happily for me, we also found that flourishing was positively and significantly correlated with higher mindfulness, although to a lesser extent. So as part of this, we've also begun to look more closely at gender-related experiences, noting this significant increased odds of high depersonalization and decreased odds of high mindfulness in females from the same survey. And then additionally, confidence intervals that suggest perhaps in a larger sample, we might reveal significant odds of higher emotional exhaustion in females or alcohol abuse in females, and decreased odds of flourishing in females. And this echoes findings that the large national survey mentioned at the beginning of this talk has also seen. So from this, we've begun to construct a first-pass conceptual framework that allows us to move away from the shotgun approach of interventions and begin to define the interrelationship of external or organizational and internal or individual factors that influence well-being. So with this, we can begin to construct an approach to this problem that integrates changes on the individual, system, and cultural levels, helping to optimize and justify the necessary resources for well-being programming. So in wrapping up, this question of resources for well-being programs and how precious they are is key. And so I frame this as a question of, are well-being programs like a rhinoplasty or like a cleft palate repair? And what I mean by that is well-being elective? Is it something that makes us feel better, but is not really necessary, like rhinoplasty, making it a matter of personal choice? Or is it fundamentally necessary, something that without which we don't function properly? Without it, we are handicapped, like being without a cleft palate repair. It is a fundamental need. So finally, in closing, no talk these days can be done without mentioning the effects of COVID-19. So at our institution, proof of the benefits of ESRT outside the laboratory setting really hit home during the onset of COVID-19. When we assayed anxiety among our residents at the height of the first surge, we were surprised to find that high or clinically relevant anxiety was markedly and significantly more prevalent among senior residents. And this was surprising because it did not jive with multiple studies in non-COVID times, which have repeatedly shown that anxiety goes down as training progresses. But then we realized that ESRT has been available since 2016, and that 55% of our current PGY 1s through 3s have taken ESRT as interns, but actually 0% of our senior residents have taken ESRT because it wasn't available. So we re-examined our data, and we found that if we looked at those individuals not trained in ESRT versus those that were, regardless of PGY level, the prevalence of high anxiety was more than 6-fold higher in those who were non-trained, and this finding was significant. So this prompted us to adapt yet again and develop a remote live stream version of ESRT, which was delivered across 4 time zones in April 2020 to academic, community, and military surgeons, and is now allowing us to continue to deliver this skill set even with social distancing. So in summary, burnout remains pervasive, impactful, and poorly understood. Individually based well-being interventions are indeed feasible, essential, and evidence-based. And changing individual systems and culture are actually all related. This argument about which one should bear the brunt is like asking, which finger is most important on the hand. And tools are emerging to help us navigate this. I will say that regardless of what tools you choose, sustainable well-being interventions are increasingly being proven to depend on iteration, adaptation, and collaboration. And perhaps even more importantly, they really do require the alignment of systems to make the intervention accessible and culture to normalize and promote its value. And without these elements working in concert, the much needed and in fact ACGME mandated well-being programs will never stick. Thank you.